So welcome everyone, and we're pleased to have you join us. We expect that more people will be popping in, but for now, we do want to get started to make sure that we have plenty of time for Sally and Kathleen and Q&A at the end. So we want to just this webinar is sponsored by the Yale Ready Hub, Rigorous, Rapid, and Relevant Evidence Adaptation and Implementation for Ending the HIV Epidemic. We are recording today's webinar and it will be made available on our website afterwards. Just to quickly highlight, the agenda will really be welcome and introduction, presentations, Q&A, closing and evaluation. We encourage you to use the Q&A feature. We'll be addressing the questions during the Q&A and the discussion at the end. There will be an evaluation survey that we're going to ask everyone to complete. It will show up either when you close your Zoom or also via email if you don't get it through the Zoom. We're excited today to be launching our Ready Hub Research Partners webinar series, really intending to elevate the power of partnerships and to feature and really put at the front the importance of collaborative, community engaged approaches to HIV implementation science partnerships, and to inspire the application of insights across research and practice settings, focusing and fostering ongoing partnerships and mutual learning. The vision that is driving this series is really highlighting the power of community and academic partnerships through first-person plural narratives, where we get to hear from multiple partners in a research partnership. And today, in our first webinar, we're excited to feature Kathleen Brady, the Director and Medical Director of the Division of HIV Health at the Philadelphia Department of Public Health, and Sally Bachman, the Dean of the School of Social Policy and Practice at the University of Pennsylvania. And they both have highly credentialed and extensive biographies, and we're pleased, but we want to give them the time to turn it over to them to share their work.
Thank you, Debbie. The next thing I'm going to do is try and share my slides. So let's see how that works. Yes, can you see my slides? Our slides?
Yes, we can.
Okay. All right, and with that, I'm going to turn it over to my colleague, Dr. Brady.
All right, thank you for joining us this morning. And so our presentation today is evaluation and optimization of the Philadelphia Ryan White EMA medical case management model. So why don't we go ahead to the next slide. So as Debbie mentioned, I am the Medical Director for the Philadelphia Department of Public Health's Division of HIV Health. So a little bit about Philadelphia. Philadelphia is the 6th largest city in the USA with about nearly 1.6 million residents. And we are a very racially and ethnically diverse city with a racial ethnic minority majority population. Philadelphia is a high HIV morbidity jurisdiction, and we are a designated Phase 1 EHE jurisdiction. The Division of HIV Health is the public health authority for HIV prevention, testing, treatment, and support services in Philadelphia. We are directly funded by CDC and HRSA. And DHH's mission is to reduce new HIV infections, improve health outcomes for people living with HIV, and ensure equitable access to prevention and care across Philadelphia. Our annual budget is about $54 million. And our approach is to provide client-centered, low-barrier services for both prevention and care, to use data-driven, evidence-based public health practice, and engage in cross-sector collaboration, as we're demonstrating today. And the example is the Penn CFAR. And our work is very much equity-driven and embedded into every program design, evaluation, and quality management. I'm going to go to the next slide. So a little bit about me. I became the director of the Division of HIV Health in February of 2021. I actually began working in the division in 1999 as a medical epidemiologist and became the medical director in 2002. I'm a physician. I did my residency in internal medicine, a fellowship in infectious diseases at the University of Pennsylvania, as well as a master's of science in clinical epidemiology at Penn. And so I've been a long-term member of the Penn CFAR. And so, but my involvement in the Penn CFAR changed about probably about 8 years ago. And I now serve as a core investigator in the Penn CFAR Administrative Core. And in that role, identify public health knowledge gaps that could benefit from Penn CFAR partnership, identify CFAR investigators whose expertise aligns with the research needs of the division, and I collaborate with the CFAR leadership cores and scientific working groups to help catalyze partnerships and streamline the use of DHH data for joint research. And this is one example. So I'm going to turn it over to Sally to hear a little bit more about
Thank you, Kathleen. So I have the great privilege of serving as the dean at Penn School of Social Policy and Practice. It's a school that's one of the nation's oldest schools of social work, and since the days when it was formed, the school has grown. We now have 6 graduate programs, and our mission is the passion and pursuit of social innovation, social impact, and social good. I want to point out that faculty colleagues and staff colleagues from Penn and from the School of Social Policy and Practice are on this webinar, and it's been really a wonderful cross-disciplinary team. While I'm at it, I want to say thanks to all the people at Yale who've been fantastic colleagues to us, including Debbie, who has been with us along this journey from the very beginning. So it's been a lot of fun to be able to work together and learning and from Dr. Brady and her team along the way. So I have a PhD in social welfare policy. My master's is in epidemiology with a heavy dose of biostatistics. And at Penn, I take on a number of different roles related to this project. And previously, I did quite a bit of work for HRSA, many national multi-site programs of varying types. And so it was a real pleasure for me personally to be invited to partner with Dr. Brady and her team so that I could continue my work in this area. So thank you, Dr. Brady, for that. And now I'm going to go back to you, Kathleen.
All right. So since we're talking about partnerships today, this project was very much a team effort. And so obviously you've just met the project director, Sally Bachman, myself from the City of Philadelphia Department of Public Health, as well as my colleague, Dr. Tanner Nassau, who's an epidemiologist and our EHE evaluator, Dr. Kevin Favor from Lincoln University, which is a local HBCU, and from the School of Social Policy and Practice at Penn, Dr. Dennis Culhane, Dr. Melinda Engstrom, and Jamie Wyatt Marshall. And not last but not least, Dr. Stephen Metro, who's an associate professor of health and social policy at the Biden School of Public Policy and Administration at the University of Delaware. So a diverse group of folks. And so, but it was beyond the research team. Obviously, this project involved Ryan White program clients who participated in the project, medical case managers and supervisors and managers that also participated, the health department at the CFAR, the director, Ron Coleman, and his team, the implementation science work group at Penn, which is now actually an implementation science core, the director of Dr. Florence Montplaisir, biostatistics core, which involves an embedded biostatistician from Penn who works at the health department, and the Ready Hub lead, Debbie Humphreys, so who has been with us the entire way. Lincoln University, and obviously the School of Social Policy and Practice team. Why don't we go to the next slide? So the rationale for this project is, starts with the Ending the HIV Epidemic Initiative, which focuses on the 4 key strategies of diagnose, treat, prevent, and respond. This project focuses on the treat pillar. And we all know that progress towards ending the HIV epidemic is impeded by health inequities. And viral suppression is more likely for people with HIV who are engaged in care. And so, and a core Ryan White strategy to promote engagement and retention in care is medical case management funded through Ryan White services. And at the health department, we actually have a novel approach to medical case management, and we really wanted to evaluate the approach. And I should mention that this project was funded by an NIH EHE supplement. And so we can go on to the next slide. So let me tell you a little bit about medical case management in Philadelphia. It's an interdisciplinary team that provides a range of client-centered activities. They do provide face-to-face meetings with clients, phone contact, and other case management encounters to assure that folks are engaging in care. And engagement in care is really the intended medical case management outcome with the ultimate goal of viral suppression. So in the Philadelphia EMA, we engaged 26 medical case management providers who offer both comprehensive and standard levels of care, which I'll talk a little bit more about on the next slide. And the goals of this binary medical case management model are to assure that people with HIV receive antiretroviral therapy and achieve viral suppression, but it provides increased flexibility to enable medical case managers to better meet the client's needs. And the goal is to be able to reach more clients by having this two-tiered system. Next slide. So for the model, so I'll just go over the differences between what we call comprehensive medical case management and standard. And as a point of reference, everyone in the prior to implementation of this model, just prior to the pandemic, everyone received comprehensive medical case management, regardless of their need. And so we implemented this two-tiered system. And so to the client enrollment criteria for comprehensive was that folks needed to have be high acuity, often have multiple comorbidities and without viral suppression. And those with for standard were low acuity and were virally suppressed. The client assessment that was done upon intake was a comprehensive assessment and plan for the comprehensive folks, and really a rapid assessment for those needing only standard. For client counseling, there was medication assessment in counseling, where in the standard group, it was just more adherence counseling. And the clients per case manager were determined by DHH goals for both of these, but overall, if a case manager was only seeing standard medical case management clients, they would have a higher caseload than those who were working predominantly with comprehensive MCM clients. The discharge protocol was very similar for both, but the time period was different. So you'd initiate a case closure after 3 outreach attempts with no in-person contact after 90 days in comprehensive, compared to 180 days in the standard MCM. And so the standard MCM was very much a light touch with fewer contacts over time compared to comprehensive. And why don't we go to the next slide? I'll turn it over to Sally.
Okay. Thanks, Kathleen. So I was especially interested in this project because I think the question that Kathleen and her team came up with is a very important one about how to optimize medical case management. And so working with our team, the diverse team that Kathleen described, we came up with 2 aims, each guided by its own conceptual model. So for aim 1, we used the re-aim for equity model, where we were analyzing differential client engagement into standard and comprehensive medical case management by a variety of characteristics, and see what we could find out about core outcomes and system outcomes using CareWare and the enhanced HIV/AIDS reporting system data. The second aim was guided by the HEIF framework. I'm going to talk about these models in just a second, where our team conducted interviews with 50 clients and focus groups with 30 medical case management service providers to identify barriers and facilitators of effective implementation, keeping in mind that this project really had a large focus on implementation, as Kathleen mentioned earlier. So we are in the process. You'll see as we're going along here, mostly what I'll be doing today, or will be doing, is sort of talking about our plan, and we're very close to publishing papers on this work, but not quite ready to present final results. So for aim 1, we analyzed differential client engagement into standard and comprehensive medical case management by these variables that you see here and the data that I mentioned previously. This aim focused on quantitative data from CareWare, EHR surveillance data. These are data in Pennsylvania. And our data analysis featured what you would expect here: mixed effects, multi-level logistic regression analysis. And it's been a very interesting process to work through this analytic plan using different types of data simultaneously. Aim 2 is a qualitative study where, as I mentioned previously, we did interviews and focus groups. Really fantastic participation with rich data from both of these groups. So our data analysis was framed by the HEIF framework to elevate themes of health equity, implementation barriers, implementation facilitators. We did dug into the literature. There's a surprisingly limited body of findings about strategies for successful case management. And as we might expect, there are a number of challenges that are faced in case management models, including client vulnerability, in terms of their holistic health status and how to think about their HIV diagnosis in comparison to, or in addition to, the other challenges that they're facing. The literature does suggest that there appears to be a potential benefit to clients and providers. And so these findings are more or less consistent with the literature on case management for vulnerable populations more broadly, which is an area of expertise for me. So as we mentioned, we really used implementation science to try to frame the work that we're doing. And so for our implementation research questions, we have been adapting a theory, model, or framework, identifying barriers to and facilitators of implementation, and evaluating implementation strategies. So we have a reasonably pragmatic approach here, and it's been a wonderful partnership working with Dr. Brady and her team to both be thinking about the science of it and the practical application of our work. Many of you probably have seen the re-aim model before. So this is a variation of re-aim for equity. And I opted out of providing references on the slides here, but just be in touch with me if you would like to have more information about this. It is an implementation focused model, thinking about pre-implementation, early implementation, and so on, with a continuous focus on sustainability and continuous quality improvement. So re-aim for equity builds on a model that's been in use for a long time, the REACH effectiveness, adoption, implementation, and maintenance framework, so-called re-aim. But this one really focuses even more on sustainability, and there's an explicit consideration of equity as a fundamental driving force in our implementation strategies. And so the idea here is that we're going to use a continuous quality improvement strategy to extend maintenance and sustaining the implementation gains. The second model we used was the Health Equity Implementation Framework, which thinks about implementation as being influenced by a number of layers of characteristics: societal influence, sociopolitical forces, physical structures, economies as the larger context, and then more meso or micro factors actually impacting the clinical encounter. I really liked learning about this model. It was the first time I had used it. I think it's particularly appropriate for work around people with HIV. Thinking about recipient factors, other recipients, the provider factors, characteristics of the intervention, and then these various levels of influence combined with facilitation, we hope will lead to successful implementation and improvements in health equity. We use this model primarily to think about the clinical encounter because we were thinking about the encounter between individual clients and the medical case manager. But we also were able to gather data related to societal influences for vulnerable populations and health equity determinants. It was a lot of fun to do this project with a team science approach guided by these conceptual models. It was great to be able to use mixed methods to evaluate the implementation of the MCM model. And we really thought a lot about how medical case management supports effective community partnerships that connects clients to support services such as housing, employment, other health and social services, as we assess the impact of the medical case management model on care engagement, retention, viral load suppression. So here was our overall logic model. You can see the inputs, the outputs, and the outcomes that we were organizing our thinking. One of the great assets here is that Dr. Brady and her team have excellent relationships with their care system. And so we did have great collaboration with the medical case management programs and good engagement from clients as well. These partnerships or these collaborations were in addition to the project team that we talked about previously. Outputs, sustained team linkages, identifying barriers and facilitators. And then ultimately what we hope happens is viral suppression and engagement in care as we improved treat and respond strategies and optimize medical case management. We wanted to build on the effective community partnerships that already existed and make them even stronger. So our focus group really followed methods for the focus group followed pretty closely the HEIF model. We had great engagement in terms of our medical case managers who participated. The prompts that we used in the focus group were derived directly from the HEIF so that we could think about our results in terms of societal influences, the context, the community or clinical setting, model components, as well as the specific clinical encounter. Our sample of medical case managers was recruited in collaboration with Dr. Brady's team. So we recruited the participants, the medical case management participants, through Philadelphia EMA agencies. And we maintained anonymity, although our team, so our school is called SP2, School of Social Policy and Practice, we worked with the team at the health department to coordinate eligibility screening and referral. So there was this was a very well thought out process to ensure that there was both clarity about the role of Dr. Brady and her team, and also the opportunity for participants to maintain confidentiality. So an email was sent to primary agency contacts, and then within those agencies, individual case managers, supervisors were asked to distribute invitations to the medical case managers, and then individuals who were interested in participating, the project team followed up with. And we spent a good amount of time thinking about this process, and it seemed to work pretty well. So a total of 25 providers participated in one of our focus groups. The participants were highly engaged in this overall area of health delivery. We had a wide range of the number of years that people were working in the field, but overall there was a great deal of experience and engagement in terms of really thinking about how to make this program stronger. There were 26 organizations that were located within the Philadelphia EMA, representing a range of types of organizations. And we ended up with 12, or almost half of those organizations. Some of those organizations had a lot of experience, have been providing medical case management services for a number of years. And just a couple were relative newcomers. The average length for these focus groups was 100 minutes. It was a beautiful thing, really, to see how these medical case managers were really interested and engaged in the discussion. So we decided that mostly today we're going to be focusing on just the results of these focus groups. So we have only an hour for this, but you can expect that you'll be seeing more results from our project in the coming weeks. So as you might expect, the results suggest that societal influences are important for understanding the patients and also the staff in the medical case management programs. There was discussion about the importance of providing trauma-informed care, and to use this perspective not only in understanding the experiences of the clients, but also in terms of understanding the experiences of the case managers. There are the longstanding issues of shame and stigma related to HIV, and it continues to be a threat to providing effective care and treatment. Participants, the medical case managers, that is, referenced policy concerns just in terms of the landscape for providing services to people with HIV. And they had ideas for how to improve, from a political domain, bureaucracy domain, larger funding issues. Now, these data were gathered a couple of years ago. We're in the final stages of getting this information out. So we can't speak to what's happening with respect to this work in the current geopolitical landscape. So here are a couple of quotes. I won't read them all, but there's some very important points that I want to highlight. Infectious diseases are not respected in health systems because we mostly serve poor people and they have Medicaid, and Medicaid does not reimburse as highly to the health system as a private insurance plan. So the medical case managers talked about themselves as being located in this equity domain. So how do people who are working in their arena of infectious diseases get enough resources to provide the care that they would like to do? And that we had a number of case managers who said things like this last sentence, but it's because we care so much and because we all go the extra mile. Another quote, something that comes to mind for me is that medical care needs to be more flexible. And I think this is an important point because the two-tiered medical case management model is an attempt to try to allow some flexibility in terms of the level of engagement with clients. So the medical case managers say they're doing their best. They're trying to make sure that they're working within the system so that their clients receive the services they need. There were also mesocontextual factors. For example, challenges in connecting and maintaining contact with patients, especially given the client population and the challenges the population faces in the context of everyday life. And this I think is not unexpected. It's something that for those of us who've been working in this field for a while, we're constantly working to try to maintain connection and contact. But this context does present an implementation barrier in terms of ensuring patients receive needed care from different types of providers. And there was an interesting implementation challenge in terms of the connection between lab results and what's happening in a more community-based organization as opposed to an acute care setting. So again, just a couple of quotes to that kind of exemplify what we found. So talking about a group that has chronic disease, struggling with adhering to their medication and coming in for doctor's appointment. It's not working. And I wish there was more support and resources around us being able to do things like maybe mobilize healthcare, and we come to you, extended hours, more transportation, and so on. So this idea of trying to have a more flexible setting. Then this next quote gets at this issue of two levels of engagement in the medical case management. And this case manager is talking about clients. They're used to a certain type of like soft touch. We need to teach people that we have definitely had issues with people, with staff coming in with their own thoughts about HIV and definitely their own stigmatizing behaviors. And like the way that they might talk to a patient or view a patient, the way they might view poverty. We've had to set people down and be like this. This is not how you talk to somebody in this clinic. And I loved the perspective here that we have a way of providing a soft touch for clients, and to the point that we're willing to sit someone down and talk to them about it. I also think that this value is an implementation context in terms of trying to sort out clients who are in more intensive medical case management versus less intensive. There were also very interesting findings having to do with the more microclinical encounter. So really these very specific clinical interactions between client and provider do impact implementation of the model. So we continue to see that there's a need for health and medical services as well as social supports. And trying to think about the different locations where this clinical encounter might happen. The medical case managers really understood the point of the standard versus medical case management model. And they were really, I think, engaged with trying to make this implementation strategy work. There's also this question of documentation and how much do we write down, and how the medical case manager is actually spending time. And again, a couple of quotes, it can come to standard patients, so that's the less intensive medical case management model. It can come to standard patients only needing one thing. And it's kind of tricky when that happens. It's different with comprehensive because it definitely gives me a break to have a standard patient. I wouldn't want to have 50 comprehensive patients because that would be overwhelming. But I think the standard patients are kind of serving as a buffer for a caseload. So we could really see that the medical case managers were engaged with trying to sort out this implementation problem or strategy. And again, so when they came up with comprehensive and standard, I would say that really helps as far as navigating case management because it gives you the idea that comprehensive patients are going to need a little bit more attention than standard patients. And we were very impressed at the level of understanding that the medical case managers had with this new medical case management model. So just a few summary results. Challenges to implementation. So the HEIF model did help us understand macro, meso, and clinical levels of implementation barriers and facilitators. And there were specific suggestions for improvements at each level, such as stronger communication, more systematic administrative support for the models. And then there are also opportunities for improvements, thinking about how do you match each patient to an appropriate level of need. The medical case managers, many have been practicing for a long time and they have strong relationships with the patients. And so it's a little tricky for these providers to change their traditional way of interacting with the clients because they've known them so long. And we thought that these relationships are really a significant strength of the MCM model in Philadelphia. So key lessons, medical case managers from a range of programs were willing to participate in the study. So this was something I was worried about. Would these folks talk to us? And they did, and they were highly engaged. 100 minutes was the average length of the focus group. And they were a very impressive group. I think that this HEIF model really worked well in terms of delivering insights at macro, meso, and clinical levels, and would be useful for others who are interested in a similar kind of a study. The medical case managers had a reasonably consistent understanding of the purpose of the program, and they were able to identify implementation improvements. And the improvements that were suggested really were at all three levels: macro, meso, and clinical. Oh, a couple of citations here just for the REAIM and the HEIF framework. I want to say that Dr. Brady and her team have taken these results already into improving continuous quality improvement in the system. And I would say from my perspective, it's just been a fantastic partnership to be able to, from our perch at the University of Pennsylvania, to be able to collaborate with our colleagues in Dr. Brady's office. So Kathleen, we made it through all the slides. So Debbie, how do you want to handle next? What comes next?
Well, I have some questions, of course. You're probably surprised at that. I am really curious. It seems like in some ways that this is an ongoing partnership between the Penn CFAR and the Philadelphia Department of Health that is both separate and a part of the Penn CFAR. And so I'm curious because when you have those kinds of institutional partnerships, the people that represent the partnership change. And so when you came to this particular partnership, where did the idea for this project come from? who was the person that embodied that idea, and then had the team that you guys pulled together worked together before. And then my third partnership related question is, what's next for the partnership?
Those are all really good questions. So I can tell you where the idea for this project came from. And this was as part of my work with the Penn CFAR. We consider them our research arm of the health department. And so on a routine basis, we actually, with my team, we develop research questions, related to HIV, both on the prevention and care side, that we send to the Penn CFAR. And so they include these topics in different ways in pilot, RFAs, and also more specifically, when they were doing the specific NIH EHE supplements that were for the CFARs and AIDS resource consortiums, they would be sent out. And so this was distributed throughout the Penn system. And Sally actually saw that information go out and reached out to Ron Coleman, the director of the CFAR, saying she was interested. And so it's basically some matchmaking that goes on through the Penn CFAR to connect researchers to the health department related to important research projects. And things blossomed from there. And Sally actually really is the one who pulled the team together on her side, and also developed the relationship with Lincoln University.
I'll just say a couple of words about this. In over the course of my work with HRSA, almost all of it has been community engaged work with community partners. And so that has become a love of mine, to not be sitting in the academy thinking to myself about what an important problem is. And so Kathleen's team, and led by your approach, Kathleen, is very collaborative, fun loving, welcoming, solutions oriented. And we have several papers that we're working on with different teams that are focusing on each one of the papers. And Dr. Brady and her team are really the stake in the ground, kind of holding the different pieces conceptually and analytically, and very importantly, the utility of the results. So really thinking about how the work that we're doing can inform the delivery of services, and also then leading to the next project. What's the, how do we continue to improve the services? And I'm constantly learning about things that you're doing, Kathleen, that are not directly related to our project, but reflect really a kind of a lifelong learning perspective.
Yeah, and members of Sally's team, Dr. Melinda Engstrom, who I think is on the call today, is also working in collaboration with the health department on another project. And I think that really kind of grew out of this work.
I'm going to chime in with a question, but first I'll just take a moment to invite all of the audience members to feel free to type any questions that you have into the chat, and we'll be happy to kind of read those and get Kathleen and Sally's responses to those I really enjoyed your presentation. One of the strengths of it, I think, is how pragmatic your approach was, and you highlighted in kind of multiple ways how you went about that. I wanted to ask a little bit about the process of using the electronic medical record, the Ryan White CareWares program to collect some of your outcomes. It's a great approach because it takes advantage of data that's already there. How easy was it for you to get the outcomes that you wanted? And I'm particularly interested in how easy it was to find the information you wanted about health equity, just because I know a lot of times health electronic records are not designed with some of those questions in mind, and dealing with missing data and getting to the information you want can be a challenge. Could you just reflect a little bit on those aspects of it?
Yes, I mean, I can certainly talk a little bit about that since we use the Ryan White data regularly for, quality management purposes, actually for other evaluations. We've used it in research as well. There's we work hard to make sure that that data is as clean as possible. But obviously it's, there always end up being some missing data. We also match it to our surveillance data. So that allows us to fill in some of the gaps, especially in terms of there's missing demographic information on folks. We have that in our surveillance data. And also if there's missing information regarding laboratory results in our surveillance data, we would have all the CD4 counts and viral loads on individuals who receive services. And so that really, I think, helped kind of I don't want to say clean up the data, but it made it much more comprehensive, and there were fewer gaps that allowed us to do the analysis. Actually, one thing I would mention in terms of the Ryan White MCM data, there were in looking at whether people were getting comprehensive or standard, there was a certain number, a small percentage of people that were really kind of getting both in the first 90 days after enrollment. And I think some of that is probably, really some issues with people adjusting to the new model.
Very interesting.
So we have a question in the Q&A, just noting that, and I don't want to massacre the name, sorry. But they note that they missed the beginning, but could you describe the engagement approach of the case managers? Or was that variable, was it decentralized? That I think the question is asking about, as the case managers were reaching out to clients, what was their engagement approach? I think that was the question, as opposed to the question about how you guys engaged with the case managers. I'm not completely sure, but if you, Trygve?
I mean, I can talk about it from the MCM side of things. Okay, that's good to know. So we have a centralized intake process for medical case management. And so everyone goes through this central process and then gets assigned medical case management at one of our subrecipients, which could be at the medical care facility that also it provides medical case management services. And so our client services unit, which does the central intake for the medical case management, would do a screener to identify whether folks they thought they should go into comprehensive or standard. But then the referral would be sent over to the medical case management agencies within, I think it's 96 hours. The medical case manager needs to reach out to the client to engage them in the services and do an intake at their end. And so there were certainly differences in the, actually what people were assigned compared to what our staff at the health department thought folks should receive. But then the engagement in was different based upon whether folks were in comprehensive or standard. So standard would be, fewer touches, really often folks who might just need that light touch, especially at the beginning, help with an application for ADAP or other things like that, where it is much more intensive on the comprehensive side. And so they typically will engage folks with face-to-face encounters, but also will do telephonic case management as well. And they accompany folks to their appointments. So it does vary to some degree, but there are specific requirements, and I don't know them off the top of my head, but the expectation is that there would be more contacts and face-to-face encounters with those who would be in comprehensive compared to those in the standard group.
So I have another question. Going back to the structure of your working group, you had a huge team. And I got to sit in on the big meetings, on the full team meetings. I'm interested in, the number of working groups. What was when you count everybody involved, how many people were on your team? And say a little bit more about the subgroup, all of the different working groups and how those happened and how those got led and run and so on.
You want me to go for that one, Kathleen? So we probably had 15 people on our team. Does that sound right, Kathleen? 15. So when we had the opportunity to apply for these funds, there was guidance in the RFP about what the types of strengths that were advised for the project team. And so certainly engagement with the Kathleen and the EMA, engagement with an HBCU, engagement with folks who understand the Ryan White care system. And so we collaboratively identified the team, and this involved, again, this isn't something that I love doing based on my prior work. It involved a lot of conversations with Kathleen, with people at the CFAR, with Dr. Engstrom, and other members of the team to find people who really have a passion for this work and would be really interested in engaging with us. The quantitative data are accessible on site at the health department, and the CFAR has analytic team members who are co-located there, and that tradition began before I came on the scene. So I'm not exactly sure how that started. But there's a very close working relationship between Kathleen, her team, and the folks who are co-located, so that it's really seamless, even though folks are from the CFAR, the university. And then we began regular meetings to both plan our approach and to troubleshoot methodological questions. You notice I didn't chime in to Kathleen's excellent description of the data. Certainly I know something about CareWare and Ryan White data, but the particular expertise really resides in the department and with the CFAR people who are co-located there. We worked closely as a team to identify strategies for the focus group, and we ended up first dividing into two big teams, quantitative and qualitative, but there were aim 1, aim 2, but there was an overlap between the two teams. And then as we gathered the data, most of the data were gathered by folks at our school, so as to have arm's length. So the medical case management staff and the clients didn't feel that they were being, followed by people in Kathleen's office. And then after the data were gathered, after the analytic databases were created, we conceptualized 2 papers for each aim. And then we have been working in those teams ever since. And we're just finishing our 4th paper draft. I mean, one of the things that's very interesting is, for as important an issue as we all think that this is, we're thinking a lot about where to place these results. So it's kind of an interesting discussion for dissemination. You want to add anything to that, Kathleen?
No, that was great.
Well, we want to thank you both. It's been great to get to hear both where you are and to know that this has been almost a 5-year process.
It's slow, yes, that's one thing.
And that when you have a large team, it often is slow. And yet I'm hearing that Kathleen and her team are already implementing some of the results.
Yes.
And so there's this parallel changing implementation practices on the ground and getting the results out in the academic literature that have happened in parallel.
Yeah. Great summary. And
Thank
it's
you.
been a lot of fun. It's been a lot of fun.
It really has been great working with Sally specifically and the rest of her team. It's been a lot of fun.
Great.
Well, thank you both. Anything you wanted to add, Luke?
I just wanted to thank you so much for kicking off the partner series. I think you two were the perfect pair to highlight the power of partnership and these impacts. And we hope to follow up with you and hear how things go over time, because I know there'll be additional lessons that we can all learn. Be well and take care.
Right.
All right. Thank you very much. All right.
Thanks a lot.
And
All
just
right.
a
Bye-bye.
reminder to the participants to please complete the survey the evaluation as you go out.
Right.
All right.
Thank you.
you.
Thanks.
Bye-bye.
Take care. Bye.
Bye-bye.